hashtag Live Surgery Tuesday. We talked about this patient who has a swan neck deformity, the finger dripping, and that's as much bend as she has. So, all right. So what we're going to do is identify other retractor, please, like a Ragnell. Making an incision between the central slip and the lateral bands. The free elevator, please. What's happening is you see the PIP joint is there. Now I'm starting to free it up. It's all scar in it because now this lady had a dislocation. She reduced it or put it back into position herself. There's nothing wrong with that. What's wrong is that you need to seek attention right away because we would have treated her conservatively and we probably wouldn't even be in the operating room today. But this is why we do this, right? This is why public and colleague education, so that if you went to a occupational health center or general kind of urgent care, you can't expect these physicians to understand this. It's not their field. It just seems like a little pinky sprain, which is what people will call it. But now we're starting to get. So I want to be, for my colleagues, obviously I don't want to detach the central slip. So now retract here. Now we're going to go on this side. So they call it transverse retinacular ligament, dividing that. Okay, so now on the scar also, there's adhesions over here. Okay, so I'm freeing up all this scar right here between the subacute tissues and the terminal extensor tendon. Okay, now, there you go. So now, little by little, we're going to regain flexion. She had basically zero motion. Okay, doesn't hold any information like that momentarily. Okay, so good. So I managed. So again, for my colleagues, run your please. I managed to protect the central slip because we don't want to get a boutonniere. So we have a swan neck deformity, but we don't want to get a boutonniere. Removing a little scar here. Okay. Okay. You can come out now. Okay. So I want to introduce, we have a pre-med student. I'm teaching them all the horrors of medicine, but also the beauty of it. So Kenneth, if you can take a picture now. We took one pre-op showing that she had basically no flexion. So now we're going to go, we're going to switch, you and I. So we did the release capsulectomy. Okay. Now I'm going to put her supine and we're going to go palmar and reattach the volar plate. Okay. 7:15. So just a standard Brunner incision. There's a lot of scar here, you can just see. But, you know, they put her, I mean, they see this all the time, right? They put her in this sort of, you know, I really think it's barbaric. They put her in this, maybe I'll send a picture of it to everyone. They put her in this thing that holds it with Velcro that holds the finger straight and goes all the way to here. I mean, I don't really know what that does other than make the finger stiff, and here she is, totally stiff. So, and again, it's like we always say, you want the right subspecialist, orders less tests, and does the right treatment. You know, in most cases, we're not perfect, but I mean, you know, when I'm with friends or something, they start asking medical questions, I go, you know what, you need to talk to a doctor and answer you. You know, I just you want to speak to the right type of clinician. All right, so we're going to open, for my colleagues, we're going to open A3 pulley. You can see there's actually blood in here from the original injury. And it's very thickened. Yes, it is. This is a swan neck deformity due to a untreated volar plate rupture with really excessive immobilization, and now she has a swan neck and marked stiffness of the finger. You saw she had zero flexion in the digit. So now I've removed freer and a right now, so I removed. So now this is the A4 pulley. I try to preserve it, but we're going to have to release it a little bit, part of it. Okay. So, right now, please. On the other side, taking it this way. You can go ahead. Right. So now this is the releasing a little bit more here, and that's more distal A2 pulley, and here's the superficialis. I mean, it's a ton of scar tissue over here. And I may need to actually release one slip completely because it's kind of merged with the skin hook on that side. Yeah, so this is the other superficialis slip. So at the end of zone 2 here, right? Well, she may not have much volar plate to be attached. Well, yeah, it's a good point. I can't, but I'm going to immobilize her the least amount of time. Let's have a 45 wire. So remember, she had a swan neck deformity, so let's understand what that is for some of the younger colleagues. So the volar plate attaches on the base of the middle phalanx, but it tore. So now her finger, the phalanx was like this. Can we get a light on here? So now her phalanx was like this. And what happens because of that, then there's a compensatory flexion of the DIP joint. And this is why it's called the swan neck deformity. So a swan, where does a swan go? Does a swan make noise? I mean, I keep thinking quack, quack, but I know it's not that. I don't know.
It's something like.
If anybody out listening knows, please tell us what a swan point it makes, because otherwise my explanation is not that interesting. But that's a swan neck, so a ruptured a volar plate. So when I want to try to find the volar plate, and I'm going to bring this down, and then I'll pin it. And to answer my colleague's question, I'll only have him pin about 3 weeks, but I have to, because otherwise she can, especially with the little finger, there's no way to well immobilize it. And I want her to start moving the DIP, because right now the central slip is a little loose. Once we bring this down, this will tighten up, and then she could start extending the DIP. Okay, so that's the problem. Now I don't want to create, that's why I was careful with the central slip. I don't want to create a boutonniere deformity. I don't know which is worse. Right. And this is a boutonniere deformity, right? Where the opposite. So this is inflection, and then everything gets tight, and she wouldn't be able to bend. So we don't want to create this. Okay, so boutonniere. And if anybody could spell boutonniere on the first try, I don't even think that's it. I was in Paris twice in the last 2 weeks. I don't know any French. All right, so here it is. So here is the hyperextension. Oh, wait a second. I see a volar plate. You see it? Right here. This is good news. Very good news, because I want to prevent recurrence. Now, usually the volar plate detaches distally. Okay, so I'm going to now make an incision in the volar plate. Go this way. I'm removing a little piece of the superficialis. Can I have add some brown or something? Thank you. You got the right instrument. Archimedes said you can move the world. But he was the guy who was in the bathtub when he said that, wasn't he? Okay, there's a bowl of plate. Okay. So, yep, so check it out, folks. So here's the hyperextension. Yeah, open the little anchor, please. Okay. There's the bowl of plate. Now look how loose that is. This is completely detached. So now I'm just gonna, it's loose, so now I'm just gonna, this is all scar tissue. That's a great question. Generally not. You don't really reattach a volar plate. You might do a rethink. You might move the lateral bands or something. Yeah, I think it's a bit different. So before I reattach this volar plate, folks, I'm gonna go ahead and pin it, because once I reattach it, it's very delicate. So I'm gonna pin it first. I do it in about 15, 20 degrees of flexion. So in other words, she may never be able to fully extend it, but who cares, right? I mean, none of the British fully extended, right? When they drink tea, it's always like this. So unless you're gonna do the robot, you don't really need to have full extension. But what she does need, and now she has excellent flexion now, so she'll be able to get a fist. Okay? So let's get that, you got that flyer?
Yep. That's a 4
Let's
5.
get Floral in here. You had to give me this one.
Just because we have to check up this drill bit
I
too.
know. All right. I'm not gonna have time to work out today, so I'll just use that heavy drill. Good news is I've done so many to use that. I can kind of do it, hold it. hold the PIP joint a little more flexion. Flexion. The PIP is right, the PIP is a little more flexion.
You're on this thing.
Yeah, I forget, you just a little, you've gone from 10 to 40, yeah. Okay. So before I cut it, I just want to make sure my estimation was good. So you see a little bit of flexion. There's no reason to pin it completely straight. I like that. Perfect, see? So, I can do it without fluoro, but obviously I like to confirm. Okay. Okay. So I always leave my pins buried under the skin. It'll be easy to get out. Sometimes I do it in the office, sometimes I do it here. Print, please. No, I wouldn't call it that. I mean, it's basically a pinning, an oblique pinning at a PIP joint in 15 degrees of flexion to protect my repair to volar plate, which Bella's setting up for me to do now with that anchor. Okay, you can come out. We're actually done with this. We're not, the anchor you don't see. Okay. We'll just need finger stocking dressing. Yeah. So, all the questions? Let me have the right now. Now I'm just going to roughen up the attachment of the volar plate. It bleeds, scars a little bit. Okay. Grill. So here's a volar plate which we're going to reattach. But there's no way to do that well without an anchor because there's nothing to suture it to. So the anchor anchors it to bone and then you use the suture on the anchor. I used to use that fancy little guide and I realized it was so small that. Okay, so this is the anchor. So the anchor is going to go in the base of the middle phalanx, and then we've already pinned this, not like this, but in slight flexion. So this will be without tension, and we're going to reattach it. No, this is a bioabsorbable. Is it PEEK or like a biocomposite? What does it say? I always forget. And as usual, Bella, you were right. Yeah, no, we don't use, because in the fingers, I mean, metal anchors, you might have little issues. 3 weeks. But a very important point is for 3 weeks, she will, on Monday, we will see her in the office, check the wounds, okay, we're gonna use absorbable stitches, and she's gonna go into a PIP finger cast, because I want her to start moving the DIP joint. Because she hasn't, I want her to focus on trying to extend it, okay? So I don't want to immobilize that, so we put actually a cast directly on the finger, done by our med tech, Gigi, who's phenomenal, and then the pin's removed at 3 weeks. Okay, so I'm about to tie this. Okay. Now, sometimes I'll try to put some stitches on the side of it, but the reality is it's so delicate that if I try too much to do too neat a repair, I don't know why I just don't cut this suture. I don't want this to be under tension. So if I put the finger straight, then the volar plate will be under tension. I don't mind if the patient loses a few degrees of extension. But if you pin it all the way in extension, this may be too lax. Okay? So, and it's also difficult to initiate flexion when the finger's completely straight. But if the finger's gently bent, it's easier to initiate flexion. It's just a principle, of PIP. You don't. Now, sometimes you'll pin the PIP completely in extension, but I will tell you, it's uncommon that I do. Okay, so freer. So now the flexor profundus, right, is sitting over. All right, my freer is inside underneath the A2 pulley. There's the superficialis. On the radial side, I removed a good part. On the ulnar side, you don't really, you can do without it. Okay, repeat irrigation. Okay, and that's it. So you can show it on a repeat. I am always amazed at how many people still remove stitches. I learned this from one of my, you worked with Dr. Corey. When Roger first started working with me 28 years ago, he told me about this suture, Vical Repeat, that absorbs. Why take up office time removing sutures, and patients don't like sutures being, so this, and I can do a nice mattress stitch, because I don't have to worry about removing it, and we can cut the knots very, very short. Okay, so at 3 weeks, we'll send them to our hand therapy colleagues, which is very important for this. And we'll probably use some type of little protective brace for the PIP joint. What other questions? So where's everybody from, Rafa? Let's usually try to take a poll. It's always interesting. Everybody, whoever's listening, you could just type in where you're from. About 10 to 14 days. Okay. I'll be there August 10th, I think. I'm doing a mission in Goa. If people don't know where Goa is, it's pretty cool. it's a seaside city in India. Anybody seen the Bourne Identity films? With that, what's that communist name? What's that actor's name?
Matt Damon?
Matt Damon, yeah. No, no, I can't comfortably know that this patient's gonna protect the finger the way they should, and to me, in 3 weeks, you don't get stiff, but that's long enough. That's long enough for the volar plate to start to scar down. I have not had a problem with, immobilizing people 3 weeks. Maybe I should go 4, I don't think 2's enough, so, it's a Goldilocks principle. Okay. Well, now let's see if it's slight flexion. You can see better on the x-ray that is. Irrigation on the top here. About what? Well, let's always keep in medicine that medicine is just as much an art as science. So I don't have published data as to why 3 weeks or why, but my data is 30 years of doing it this way. And I'm open to change. I mean, if somebody has a good argument as to why it should be less time, it's just that I think it's long enough to protect and allow for early healing. But in 3 weeks, people don't get stiff. Same with elbows. I do, after I do a radial head ORIF or something like that, I usually, long arm cast, and I start moving them in 3 weeks. 3 weeks has been my friend. Yeah. Oh yeah, this is a repair of a delayed repair of a volar plate, but the patient is 5 weeks out, so she had an extension contracture. So the marking. Yeah. So I'll show you in a second. So we had to go first on the top to release the, without disturbing the central slip. We had to do a dorsal PIP capsulectomy. So that's the problem with delay. If I'd seen her earlier, I might not have had to do the dorsal. And it's kind of a lot of surgery for a little finger, but I mean, I've done this before because this is the unfortunate scenario with a lot of healthcare issues is people come late. And sometimes it's their fault, but a lot of times it's just the system. And those who know me know in my stubborn way, I'm trying to improve that. At least have people pay attention. Because, this is, the reality is if we saw her, say at our walk-in at Ortho Now, she would have had a PIP finger cap put on right away. She probably wouldn't be having surgery. She would have had hand therapy. So what happened is because this was, and we saw inside, you saw this was detached. The capsule, the central slip a little bit, but mainly just the capsule and the extensors are tight. So we have to do a capsulectomy to allow the middle phalanx to flex. So we have a picture of her doing this now, whereas before, she was in hyperextension. She had no flexion. Right, Josie? She had no flexion. When she made a fist, so I put out in the story, was it a story or reel? I forgot.
I can show the pictures if you like.
Yeah, there you go. Thank you.
It was the before.
It's as far as she could bend. She had no flexion. Yeah.
And it was the after.
And there now, yeah, excellent. And you can see the interval between the central slip and the lateral band. So on either side. Okay. So what we do now is just a little finger dressing. And this will be switched next week. So very strict elevation of the hand. And it's always really important for people to understand how, because it's all gravity. The second we release this tourniquet, she's gonna obviously swell. But we can minimize that. Okay, tourniquet down.
Okay.
Tourniquet time is?
36 minutes?
36. We anticipated. Okay, so just make sure she stays elevated, you know, grip the tape,
Maybe with
can't be wavy. Okay. Okay. That's it. Okay, any last questions? So did we get where people are from? We have India.
Yeah,
300 and something people liked the announcement, so I think that we have at least, we haven't done this we haven't done a large surgery tube in about 6 weeks. I've been traveling, but yeah, usually we have about 150 people. So, all right, well, you guys know how to reach me. Any questions, happy to answer, but important thing is to keep learning always from each other, so have a good day.